The following is our technique guide for in-office and in-OR needle endoscopic plantar fascia release for chronic plantar fasciitis. Advantages of this technique include the utilization of only one portal with a smaller incision, which can result in reduced postoperative pain and a quicker return to activity. In addition, this procedure can be performed under local anesthetic and therefore can be done in the office setting with the patient awake, thereby avoiding anesthesia-related complications when performed in the operating room. Limitations of this technique when performed in the office setting is the need for a separate open incision if nerve decompression or resection of calcaneal enthesophyte is required. The patient is placed supine and the foot is prepped in normal sterile fashion. Instrumentation includes a 1.9 millimeter needle scope, a dilator, and an endoscopic center release. A 2 cc mixture of lidocaine and marcaine is then injected just proximal to where the incision is made. A 5 millimeter incision is made directly over the medial aspect of the plantar fascia insertion, just distal to the medial calcaneal tubercle and proximal to the border of the glabrous tissue. Careful dissection down to the plantar fascia insertion is performed utilizing a hemostat, taking care to avoid dissection dorsal to the fascia to prevent iatrogenic nerve injury. The dilator is then introduced and gently advanced plantar to the medial aspect of the fascial band to create a portal and potential space for the 1.9 millimeter endoscope and the endoscopic center line release device. The needle scope is then introduced into the release device. The plantar fascia can be viewed utilizing the needle scope. The foot should be held in a dorsiflexed position to tension the plantar fascia and surrounding tissues. Once the plantar fascia is visualized, the scope is advanced to the most lateral extent of the fascia, and the endoscopic cutting blade is then released with the tip of the blade directed upward. The blade is then directed from lateral to medial while applying upward pressure for complete release of the fascia. The release is complete when fat and underlying intrinsic muscle is visualized across the width of the release. Multiple passes with the endoscopic release system may be required to ensure complete release. It is important, though, to be careful with an overly aggressive release, which can increase the risk of lateral plantar nerve damage. The wound is then irrigated and the skin is closed with nylon sutures. A bulky, sterile, soft dressing and a postoperative shoe is applied. The patient is made protected weight bearing on the operative leg for 2 to 3 days and then progresses to weight bearing as tolerated once the sutures are removed. When performing in the office setting, patient selection and a thorough pre-procedure discussion is critical. You must also allow adequate time between anesthetic administration and procedure. The release should be performed under direct endoscopic visualization to ensure complete release and to ensure that there is no nerve involved. Pitfalls include poor portal placement, insertion of the scope dorsal to the plantar fascia, and an overly aggressive release, which can increase the risk of lateral plantar nerve damage.